Okay, we're live.
Okay. Hello and welcome. Today we have another fresh dental shadow session with Dr. Alex Rugina, and he can take it away.
Yeah. Hi guys. Nice to see you. I hope this session is going to inspire you to do nice things in dentistry. By the way, I'm from Romania, so it's a little bit far from you guys, but maybe we'll see each other at future conferences, maybe online or something. The main topic that I'm gonna talk about today, it's about full mouth rehabilitations. It's my main passion in dentistry. A little bit about my background. I finished the dental school in Romania in 2011, and I've been practicing in private practice ever since. I own my own clinic in Romania, in Timișoara. It's a really nice clinic, and I managed to do this complex full mouth rehabilitations, and it's something that inspires me to go in the practice every day. So hopefully you're going to find it interesting, and it's going to motivate you to be 100% in your dental school learning curve, because it's a learning curve, and everybody has to do it. So I'm going to jump right into my presentation. The presentation is called Full Circle because I would like to talk about the whole image that we see in our patients, not only the minimal preps or only the endos and only the implants and so on, because that is just a little bit of just a little piece of the puzzle. And as dentists, especially if you're doing prosthodontics and full mouth rehabilitations, it's your job to see the whole patient. So I'm gonna show you how I've managed to transform this kind of cases, like this one with tooth wear, in this kind of cases. And today everybody likes to see really beautiful finished cases, but usually when you see a really nice aesthetic case, the work behind it's colossal, and we have to study a lot to know all the pathology that we have to treat before we have to approach these cases, because a big mistake would be to rehabilitate this kind of tooth wear without knowing the cause. The thing is that in cases like this, the tooth wear represents only the symptoms, but not the cause of the problem. The root of the problem, it's our job to find and to treat. I'm going to show you how I've managed to treat cases like this and turn it into this, and cases like this that seem hopeless into cases like this without pulling the teeth out, and cases like this into cases that are stable like this, and cases such as this one into cases that we love to see like this one, and cases like this that transform everybody's life and confidence, and maybe cases like this that are a little bit more dramatic with accidents, and to turn them into something positive. So if you'd like to see some of the main focus in my approach, I would like you to stay tuned up for the next 40 minutes or so. I'm going to try to be really focused on the objectives, and the main thing that I thought that I was taught is that we have to be really precise with the preparations and with the impression and so on, but that's not enough. In this kind of cases, where we have to treat cases of full mouth rehabilitation, it's really important to look past those simple things that have to go well. Those things are important, but it's not enough to manage a case like the ones that I've shown you. We need to focus on some other aspects as well, and I'm going to go step by step with you through some of them, and I want to show you how much of an importance they have in our daily practice. the main objectives that I have when I'm treating cases of full mouth rehabilitation are these: is the facial harmony of the patient, the orthopedic stability, the occlusal stability, the pink harmony, and the white aesthetics. And we're going to walk through all of this step by step, starting with the simplest of them, which is the white aesthetics. Mainly today, we are in an era where we are so focused on the aesthetics and the cosmetics of the cases that sometimes we forget about the other objectives. And that's not the ideal approach, because without good basis of our cases, the aesthetic is going to fail really soon. The best idea is to stabilize, to have a good basis, to have a good occlusion, to have a good facial harmony, to have a good orthopedic stability. And just after those, we can focus on the aesthetics. So, as I was telling you, the white aesthetics, I'm going to talk about this with this case. And this is the case of one of our colleagues. She's a dentist also. And the case is really complex. It's not just about the aesthetics, but I'm going to talk only about this aesthetics. The case is a full mouth rehabilitation. The patient had TMJ problems and pathology, but that's a story for another time. So as far as the aesthetic goes, of course, we can improve this smile quite a lot. You can see that the buccal corridors are really wide, and we have tooth awareness. So what can we do with this patient? First of all, this is the initial situation. First of all, maybe you've seen this before, I'm sure you have. It's a good idea to try the shapes that we have in mind, to try it with plastic. That's a mock-up. And why we are doing this? Because it's easy to correct and adjust, and cheap and fast. It always allows us to see if we are on the right track. And if some modification are needed, it's really easy to do this with the mock-up and with the plastic than to try to modify the final restorations. It's much harder. So that's why it's a really good idea to have this trial with mock-up. And if you want a comparison, it's like playing golf. You're not trying to put the ball in the hole from the first shot. You first hit the ball and try to get it as close as possible to the ball, and only when you are a couple of yards, I don't know, meters. This is a metric Romania system. Only when you're inches from the hole, if you like, then you push the ball in the hole. So this is the mock-up in dentistry. It allows us to see if we are on the right track and gets us closer to our main objective. So this is my protocol always. We can have as many provisionals as you like, but it's ideal to only have one final restoration. So we're checking again our objectives. And in this case, we're doing the wax-up. If you want an advice from me, especially, I don't know how the dental system works in the States, but in Romania, in the dental school is not common to do this kind of wax-ups. So if you have the opportunity, the investment you have to do to buy the tools needed for wax-up is really nothing. It's really cheap. So maybe with $100 you can buy the tools needed for doing a wax-up. And for me personally, when I started doing these wax-ups, it was, I think, the biggest leap that I have in knowledge about the cases that I'm treating. So if you want, maybe the best advice that I can give you guys right now, it's if you have the chance, buy the tools, and in your free time, in your spare time, try to model some teeth that you think are going to look good on a patient, and then try to do a mock-up and see what happens. You're going to learn a lot. I still do my own wax-ups even today. So these are the shapes of the tooth. You can see that is not only an aesthetic wax-up, it's also a functional one, because we have to change a lot on the occlusal part as well. So this is our patient after the mock-up, with the mock-up. So now we can evaluate if we are on the right track. If everything fits and we have all our objectives reached, then you can use the mock-up. You can see the final result, the mock-up result. It looks already really good. And you can try to copy the mock-up into the final restorations. Before removing the mock-up, you can check also the occlusion, and this is by manual manipulation. If you had studied Dr. Dawson from the US, it's one of my mentors. I don't know what literature you have from the school, but I would advise you, if you have the time, to read Dr. Dawson's book, Peter Dawson. So this is the manipulation, and you can see that it's really easy to do this. And if you'd like, I don't know how far along you are in the dental school and the dental knowledge, but in full mouth rehabilitations, we also we always like to start from a stabilized position of the condyles and with relaxed muscles. Why? Imagine that you have to do the occlusion in an articulator. It's really easy to do that because in the articulator, the models never change position. And that's why it's really easy to adjust the occlusion like that. Now, imagine that we also need this in the patient's mouth. So my advice is that you can start from a position like that after you decompress the articulation and the TMJ and also the muscles. And why? Because you also need this kind of position when you can where you can lead the mandible in the same position all the time, always. And that's really important, because if you have muscle tension or something wrong with the TMJ, then it's going to move like this, and the occlusion is not going to be stable. And that's why you need to do this kind of work after you've dealt with the TMJ problems. This is my advice for you, and I hope it made sense. This is the simple explanation why we should start from this position. After that, also we have to check if we have a good disocclusion of the posterior when we're doing the mandibular motion, and also if we validated the mock-up aesthetically and functionally, then we can try to copy this on the finals, and we can do this by providing the dental technician with some information. The information that I give to my technician, consists in pictures, and this is the protocol of pictures, and also consists in impression of the mock-up and of the result that we got into plastic. And maybe it's a digital impression or analogical impression, it doesn't really matter. The main idea is to provide as much information to the laboratory as we can. So we can also use the mock-up to cut through it and to have the so-called solution-driven preparations. It's a concept that was first introduced, to my knowledge, by Dr. Galip Gürel from Turkey, and it's a concept that provides some guidance to the preparation. So we have to cut as little as possible from the tooth structure. So you can see that the reparations are really thin and really minimally invasive. After that, we take the impression and the restorations from the laboratory come in the office, and we have to do the bonding of the restorations. And it's a good idea to use the rubber dam. I always do it. If you're not really confident in your skills with the rubber dam, I would advise you to try and manage as good as possible this kind of thing. And it's a process of trying and learning. And of course, when you first try to have an isolation, a good isolation is going to take maybe 1 or 2 hours to place the rubber dam on an arch. But as you get good with time, maybe it's going to take, in cases like this, 5 or 10 minutes, and then you're going to have the whole procedure under perfect conditions. So it's another advice that I can give you. Try to get good with the rubber dam. It's going to help you a lot in your career. This is the final bonding of the pieces of ceramic, and this is after we clean the excess. So you can see a good integration of the ceramic. It looks natural, and also it functions really good. This is immediately after we've placed the veneers. So we talked about pink aesthetics, about white aesthetics. Now let's see what we can do for the pink aesthetics, because most of the times this is harder to manage than the white aesthetics. And in cases like this one, if the patient comes for the first time in your office like this, and the patient says that the ortho is done, it's finished, and you have to continue with the prosthodontic work from here, is not going to be a really comfortable situation, because the patient's expectations are really high. She went through 3 years of ortho treatment, and the result is far from being satisfying. And she expects that after she's going to have the final prosthodontic work, everything is going to look great. And that puts a lot of pressure on our shoulders. So let's see what we have in our hands. You can see that the periostatus is far from ideal, and we can also see that we have some provisional over the patient's teeth. The main problem with these provisionals, I don't know in the States how the protocols work, but in Romania, many times, dentists, because they are in the rush, like everybody, they are putting this kind of restorations, provisional restorations, they are bonding them with provisional cement. And that's a really terrible idea when we are talking about long-term treatments. Why? Because the provisional cement is going to get bacteria inside, and many times, if you undergo orthodontic treatment for 3 years, maybe, or 2 years, or even shorter, for 6 months, you're going to find that the abutments, the dental abutments, are with decay. So that's a shame. And another advice that I can give you is, if you have to put provisional long term, please cement it with final cement, with glass ionomer or whatever you have in your office that it's considered to be final bonding cement, final luting cement. So we check again our objectives, and we can see that the pink objective of our restoration is far from ideal, and also the white. And you can see that we have on the left side of the screen, we have a canine that was brought in the place of the lateral, and the lateral is missing. And we can see on the right part of the screen that the lateral and the canine are missing. So because they were extracted and moved orthodontically, you can see that we have a really big defect on the part where the tooth were extracted, and we can see that we have a really big bone in the central incisors area. So we have to manage this case in such a way that we reduce that bone and make it as uniform as possible on the front. You can see that I've tried to see if in these cases I can distribute the spaces as best as possible. I've done the surgery, which involved full flap, reducing the bone in the central incisors area, and having a roll flap tissue graft, in the lateral area. You can also see that between the two central incisors, I've reduced the bone with a little bit of concavity because this is the natural shape between the roots. The surgeons know that many times is much more important what you are doing with the bone, not only vertically but also horizontally when you're doing this kind of gingival plastics. So this is the first mock-up after we've managed to do the periosurgery. And still I thought it's a good improvement, but I still thought that we can do better. And I've done a second mock-up. This is the fun part with and the good part with the plastic, that you can modify it as many times as you like. These are the tissues after the tissues healed. And this is the second mock-up, and you can see that already the case looks much better, and now we can think that we can try to provide the final restorations for this patient. So you can see the finals over here, and you can see the comparison between the two situations. And you can see this beautiful patient with a smile that she deserves. This is the lip at rest position and the full smile position. It's a really nice smile, and the pressure was really high when we tried to manage this case. So in this kind of cases, my best advice for you would be never try to go directly to the final restorations. Always try to use plastic to provide a good idea if you are on the right track or not. If you can't do a good plastic and a nice mock-up, you're not going to be able to do a nice final result. So another thing that we have to take into consideration when we are rehabilitating patients like this is the facial harmony. And what do I mean with this? I'm going to show you two cases that are similar in some ways, but really different actually. So this is a patient of mine that came, and he had some provisional work done, and he didn't go to finish his treatments, and he was with the provisional work for 5 years. And after 5 years of provisional works, this was the result. You can see that the tooth are really badly damaged with cavity. So if you only look in the mouth of the patient, this kind of teeth look like they might have to be pulled out. But if we take another look, we can see that maybe we can put the crowns a little bit more apically. So we have to check our objectives again, and we can see that we have a vertical excess in this patient with large gummy smile, and that helps us to move the crown a little bit higher. And that means that we have to cut from the incisal part and also do crown lengthening So with the crown lengthening done, we can also provide some good ferrule effect for this prosthetic, for the final prosthetic restoration. So let's see what we've done over here. This is direct mock-up just to see if after we're doing what we've planned is going to be aesthetically okay for the patient. So you can see that even if I cut from the incisal edge 1 or 2 millimeters, he still has a big exposure on lipid rest. So it's not a problem to reduce from the incisal. Why? Because the patient is hyperdivergent. So we're doing what we've planned. And you can see that we approach this case, the canines first, and you can see that we've raised a flap, and look what beautiful dental substance we found on under the gingival level. We build up the, of course, root canal treatment, and we build up the abutment, and you can see the difference before we modify the provisional. You can see how much we went to the apical. So this is the provisional after we modified it, and you can see that the abutments now look really good with good ferrule effect and with nice dental substance. So in this case, because we looked on the outside, we managed to save the frontal teeth of the patient and also provide a superior aesthetic outcome than that we would have with dental implants, and much higher rate of success long term. Of course, on the lateral part, on the back of the patient, we have to use implants for the final restorations because he didn't have any teeth. This is the status before and after the crown lengthening. You can see the bone that we cut off, and you can see with provisionals how the patient looks after he was healed after the crown lengthening. So from here on now, it's a case of quadrant dentistry that is really good. And you can see that we've rehabilitated the posterior with dental implants and also on the upper. And this is upper and lower, and this is the final result. And you can see that we've managed to save the frontal teeth of this patient just because we were careful to look also at the outside. And the result, it's really nice. This is immediately after bonding. And you can see the patient that still exposes a lot of smile and incisal edge, even though we've lowered his low part of the face. And we managed to do this because he was hyperdivergent. Another case that is similar to the first one is this one. And in this case, you can see extreme awareness of the teeth, but in some respects, it's exactly like the other one because it's missing a lot of tooth structure on the upper. And we've seen that in the first case, I managed to buy some tooth structure by moving the crown a little bit more apically. But in this case, if we are doing the same thing, it's going to be a big error because look at this patient. What do you see when you see this patient? It's a hypodivergent patient. So his lower part of the face, it's quite small. And if we're doing the same procedure to this patient, it's going to be a big disappointment for the both of us. So in this case, it's really important to increase the video. So again, we're checking our objectives, and this is the mock-up that we've managed to do for the patient. And these are the build-ups. We didn't do any root canal treatment. It's a really important patient for me because he's my own father. So I tried to stay as little invasive as I could, like I do with all my patients. So these are the preparations after we've done the build-ups, and you can see the final result after 1 year. This is the follow-up on 1 year, and this is the patient, and you can see the X-ray, the control X-ray after 2 years. Also the posterior parts were rehabilitated with using implants, and on the upper you can see that there are no root canals. And this is the profile X-ray, and you can see that in this case, if you are decreasing the VDO, it's going to be a big error. So this is 3 years in use, and you can see here why it's really important to also check the full face of the patient so you can have a really good decision when you have cases like this. It's a big difference that makes the difference. Occlusal stability is another key factor on full mouth rehabilitation. What do I mean when I say occlusal stability? I mean that we need to provide, after a full mouth rehabilitation, we need to provide to this kind of patients simultaneously multiple contacts in CR if possible, or stability position, call it whatever you like. And this is one of the objectives that we had with this patient also. It's a class 2 patient. You can see that the mandible is really retruded. You can also see this on the X-ray, and in this case, we decided to do ortho on the patient only on the upper arch. It's a really rare decision. We usually do ortho on both arches, but in this case, you can see the initial situation, not a really good situation. You have to clean everything up and get rid of all the cavities and all the bad root canals and all the calculus. And after you clean everything up, we are going to do ortho. And as I told you before, it's really rare that we are doing ortho only on the upper jaw, but in this case, we've had this idea because if you can see, the mandible bone is really retruded, and the incisors are really inclined to the front, and this helps us a lot to reduce the step between and the space between the upper and the lower incisors. If we are going to do ortho on the lower, the treatment is going to bring the incisors back, and then the gap between the upper and the lower is going to be impossible to close only with orthognathic surgery, which was not an option for our patient because he didn't want it. So after ortho, this is the situation, and now we're going to do the same protocol that I've talked in the previous cases, and also we're going to register again the patient and treat it like a new case because after ortho, everything changes. And we're doing the wax-up. Today, you have the possibility to do digital wax-ups, and that makes life really easier. This is a case that I've treated 6 years ago. I didn't have these tools available. And this is the mock-up. And again, we're going to check if all our objectives are met, and we can try to see if we have multiple contact points in CR, and we also check the mandible excursions. if you have cases like this with the mandible that it's a little bit to one side, it's a good idea to provide more than two lines, because you need for guidance, because you need to engage more than one tooth in this movement. The ideal situation in these cases is to engage all three incisors on the lower jaw. And usually, if you have a good midline that coincides with the upper one, you're going to need at least two pairs of teeth that are going to two teeth in the upper and two in the lower that are engaged in this motion, so we can have good stability. This is the mock-up, and after we validate it aesthetically and then functionally, we're going to try to copy this on the final restorations, just like we've seen in the previous cases. And these are the final restorations. You can see the hygiene of our patient is not ideal, but you can see that we provided multiple contact points in CR with this patient, and this gives us occlusal stability long term. And we managed to provide good path of guidance. And this is the result after we finish the case. And this is the recall, the follow-up 3 years in use. Still good. The hygiene is not ideal, but this is a really quick fix with hygienist. You're going to solve the problem. So this is one of our objectives, to have as little repairs done as possible. And this is the dental hygienist is not actually a repair. It's something that it's a maintenance work. Another key factor in our practice when we are doing this kind of rehabilitation is the orthopedic stability. And I've talked a little about this in the previous cases. And that means that we need to see and check our patients, because some of them are really young, like this patient. Her name is Andrea, and she's a professional tennis player. She actually trains right now in the States. I think she's in Florida or in Miami, something like that. So you guys are really close to her geographically. And Andrea came like this, and she was, of course, interested in improving her aesthetics. But as we take a closer look, of course, we can provide a nice aesthetic outcome, but we have to check everything so that aesthetic outcome is going to be long lasting, because as you can see, you have some tooth wearness, not a lot, a little bit, but then again, she's only 17 or 18 years old. So these teeth are not supposed to look like that in this age. You can see some tooth wearness. And if I'm going to place some veneers over here, if she's going to wear her natural enamel, what will happen to my veneers? Maybe they'll chip, maybe they'll fall, or so on. And these are accidents that we don't need. So let's see why this is happening. You can see the bite is really, really strong. It fits really well when she's biting. But when we guide her in CR and we mount the models, this is the initial situation, you will see what happens. First of all, we are trying to do a nice aesthetic job for this patient, and we've done on wax-up. And this is the aesthetic part of the wax-up that I'm doing myself. It involves a lot of knowledge. And if you do it yourself, you're going to gain, you're going to have a good leap, and you're going to progress really, really fast in your knowledge. This is the final result on the aesthetic part. And now you can see that when we mounted this case in CR, you can see that we have a big gap between the lower and the upper arch, even though we had an almost perfect fit when the patient bit naturally. So that means that the patient is going to guide her mandible using the muscle, and that is going to create some muscle tension and is going to develop the muscles more than we need to, and maybe the chewing force is going to be greater than we need, and that's why she's sliding on the anterior and she's wearing her frontal teeth. So we're going to need to address this problem, and we can close this gap in 3 ways. One of the ways is to cut down from the back, or to add on the front, or maybe combined, or if we are too invasive, then we can maybe use ortho treatment. But the main idea is to check these options first on the models. So this is what I've done, and I've tried to get as much as possible contacts on the posterior, and you can see that I started to cutting down until I've managed to get some contacts from the bicuspids back. And now you can see that the gap is much smaller. From now, we're going to try to manage the lowers and the back of the uppers. And you can see that we have good contacts everywhere, and we've closed the gap really good. And now we can provide the same outcome in our patient's mouth, but first on the model. And now we're going to do the same in our patient's mouth. So you can see here the mock-up. We had to do some crown lengthening on the central incisors. You can see that we've used the mock-up as a guide, and we made the modification on the lowers also, and selective grinding. You can see the contact points on CR, and now we're gonna replace the mock-up. I like to build this part of the tooth, the oral part of the tooth. I like to build it with composites, and this is what I've done. I replaced the mock-up with composites, and you can see the composite on the centrals first, and then on the laterals, and you can see that we've provided nice anatomy and good contact points. This is the manipulation in CR. You can see how easy this goes. And you can see the contact points that we anticipated on the models. You can also find in our patient's mouth. And now, the guidance pathway on the centrals and on the canines. And we can see nice disocclusion of this patient. And you can see already that the aesthetic outcome is much, much better. And now we've transformed a hard case in something really, really simple of 8 veneers. And now we can use the mock-up to prep through it, and also provide some really thin preparation, some minimal invasive dentistry. You can see that the preps are really, really thin. And this is the impression stage and the final restorations that we've made for this patient, the bonding procedure that I've got you used to. This is after bonding, and the final result after we've removed the rubber dam. you can now see that we have a nice outcome and also good occlusal stability and orthopedic stability. We also provided a splint, a night guard in form of a splint for this patient, and you can see the occlusal check at the final restorations that it's really good. A lot of contact points in CR, and also the pathways. So now we can enjoy a really aesthetic outcome, but also we know that it's functional and it has all the right premises to last a long time. You see Andrea in the beginning, and she looks like a top model after this procedure. She looks much nicer, and she's much confidence. She has much more confidence in herself, and this is going to help her in her career of professional tennis player. So we've went through all these objectives. Now I would like to show you how I use the mock-up to actually see the future. I've told you that if I have one secret in these big cases of full mouth rehabilitation, is that I try to get the most of the mock-up. And this is a last case that I want to show you, where it's a difficult case, and I'd like to show you how important these objectives are. So this is a patient that we started treating, and while we are doing the treatment plan for this patient that is going to involve maybe ortho and perio surgery and full mouth rehabilitation with prosthetics and maybe restorative with composites on the lower. This was the initial situation, and meanwhile, the patient unfortunately had an accident, and she fell from the stairs of an airplane. So she got like this to us, and you can see that the central incisors, the frontal teeth on the upper jaw, are pushed inside, and fortunately that was no fracture. And after the doctors from the ER stabilized this patient and made sure that she had no immediate threat to her life, we went in and we've done an anesthesia, and fortunately we already made a splint for this patient, and we used that splint to push the teeth in exactly the same position as before and to stabilize the teeth with that splint. Of course, she was instructed not to remove the splint at all. So another problem that she had is that you can see the second day she has a big hit on the mentonier part over here in the chin, and when you see this, you have to wonder if maybe the condyles are fractured or something happened to that part of the bone. Fortunately, it wasn't the case, and you can see the splint and immobilized teeth on the upper. So now this patient eats with the splint, because if she removes it, the teeth will not come together correctly and she's gonna be in pain. And that's why the deprogramming and the stabilization of this patient went really well, because she was forced by the circumstances to wear all the time this splint. You can see the calibration, and now we're gonna do the same protocol that we've seen before. Another thing that you have to take into consideration is that you can see the lips of the patient. She has really thin lips, but now she has lips that are a little bit better. And why is that? It's because she's wearing the splint, and that means that if we're gonna do the teeth a little bit to the front, she's gonna have a better lip support, and that's gonna help her aesthetically at the end. And this is something that we have to take into consideration. Most women nowadays like their lips to be with good volume, and if we can provide them that for them, it's going to be a bonus. You can see the situation without the splint, and you can see that the lips almost disappear. On the left side of the screen it's without the splint, and on the right it's with splint. And another thing that we can see is that she exposes a lot of the lower teeth, and she doesn't expose the upper teeth at all. And that's a big problem, because patients like this look really old, much older than their actual age, because as we grow old, oral soft tissue tends to go down. And that means that if you show a lot of incisor on the lower, you're going to look old. And if you don't show a lot of incisors on the upper, also you're going to look old. And this is something else that we have to take in consideration. And also you can see that when she smiles with her whole smile, you can see that she almost has gummy smile. And that means that she has a really mobile upper lip. And that's again another problem, because in this position, if we have to lower the incisal edge of the upper teeth, it's going to look really bad, because we're going to provide a really, really big central incisor on the upper. Another thing that we have to see is that this patient, look, this is the splint, and looks how good this works with the splint. And we have to do the mock-up. When you're seeing the mock-up, when you are in doubt, use the plastic. It's really important, because sometimes cases like this are really hard to manage if you don't do a try-in. And you can see that in CR, we have a little bit of space, and this helps us. I don't know if you noticed, but the patient has some tooth wear on the lower that are to the buccal. And that usually means that you have a class 2x2, and the uppers are a little bit to the oral, a little bit inclined inside. And when you're seeing tooth wear on the lowers that it's buccally, you can imagine that in these cases you have a restrictive envelope of function. And that's a big problem, because there are studies that tell us that an inclination of the pathway with 10 degrees tends to increase the muscle activity by 35%. And that's why this awareness appears. And we have also to consider this when we are doing the mock-up. So the first time I've tried to go with my central incisor a little bit more buccally, so I can provide some lip support, and to place the incisal edge a little bit lower. Look how much volume I've done for the frontal teeth on the upper. Now, if we're going to leave the incisal edge like this, it's going to be too thick, and the patient will not like it. And that's why we have to cut some teeth out like this to make a much more thinner edge. These are decisions that it's best for a doctor to do than a technician. You can see the frontal 6 and the back teeth. And now we can see that with the upper, the ideal form, you have this gap. And this gap can be closed in two ways. One of the ways is to elongate the lowers, but that's a problem because if we're going to elongate the lowers, the patient is going to show much more than she already showed. So we're not going to be able to go up with the lowers. But a good idea is to go in front with the lowers and also put some material on the uppers on the palatal side. So if we're going to do that, we're going to have to reduce a little bit from the lowers and also from the lingual part, because otherwise, if we're going to add to the buccal part and we're not going to reduce from the lingual part, they will be too thick. And we're going to place the buccal part of the frontal teeth on the lowers like this. And this is a big, big change. You can see this. And now the gap is much smaller, and it only remains for us to add on the uppers like this. And now we've closed the gap, and you can see that the pathway is much, much better inclined and has a much shallower angle. And that means that this patient is going to be able to do all the mandible movements with not such a great effort from the muscles. Okay. She still is a class 2 patient. There are some things that you have to take in consideration when you're doing occlusions for the class 2 patients, but this is a discussion for another time. And this is what we've done with the wax up in this case. And of course, now we've simulated this on the models with wax. We have to do it in the patient mouth. And first of all, I wanted to show you that I've done some silicone key index, and I've done the whole arch on the lower by hand with composites. And I've done exactly what I've simulated on the models. I've reduced the incisal edge. I've cut a little bit from the lingual part of the tooth. I cleaned really well the tooth. I isolated with rubber dam. This is really important, and you have to know what you're doing when you're providing this kind of treatments. And I've modeled with composite resin the teeth, and this is immediately after I removed the rubber dam in the same meeting. And we still have the mock-up on the upper, and you can see that the gingival part of the centros is not ideal yet, and it's going to require some perio surgery. And we've provided this perio surgery. One of my colleagues, Dr. Dan Bleba, provided this kind of surgery. And you can see that we've tried to cover the defects. This was before, and this is after. It's a much better situation. And this is the patient after the graft, and this is before, and she still has the mock-up. This is with the mock-up, and this is without, and you can see that the profile is also improved, and also the lips are a little bit thicker. We've provided with the patient with the final restorations on the back of the upper, and we still waited a little bit for the perio tissues to heal after the surgery. And now all we have to do is to, after the healing, is to prep the teeth for 6 veneers. So we've managed to transform a really complicated case in something really, really simple that we all enjoy. You can see here the tooth preparation on the upper and the final restorations and the rubber dam isolation, which is really important in these cases. And you can see the final restoration immediately after I remove the rubber dam. This is the initial, and this is the final. Lip at rest. This is the initial, and this is the final. And we can see a much, much better situation than it was before. And the stable situation. And the patient looks much, much better, but also she's much healthier. So if you liked what I've shown you, maybe, I don't know, you're in the States, guys, but maybe, who knows, maybe your journey will take you to Romania, and maybe you would like to see something about tooth preparation. I have a course dedicated to this subject, and also I have a course that is dedicated to full ceramic restorations like veneers and onlays and inlays and so on, and tips and tricks for rubber dam isolation, and clear protocols about bonding, the restorations, and the minimally invasive preparations. So it's something that you could consider. I'm sure that are much, much cheaper than the courses that you have in States. I also have a good Instagram page. I would advise you to, if you like my work, to follow me over there, because I try to post as much as I can. And also I'm planning a full mouth rehabilitation course for the next autumn. And these kind of big cases that you've seen over here, I'm planning to do something in more modules, so I can show better my work, and to teach the attendants to have this kind of results themselves. So thanks a lot again. Hopefully it inspires you to do quality job in your field, and to become a name in your field. And why not? Maybe we can. The world is much smaller than it used to be, so maybe we can meet each other at some conferences, or maybe you decide to visit Romania. It's a really nice country. Also Timișoara, the city I'm in, is a really nice city with lots of things to do. So if you have the opportunity and you want to do a European adventure, why not Romania? So thanks a lot again. Are you still with me, guys? If you have some questions or something.
First and foremost, I just want to thank you for the very informative presentation. I don't have any questions right now. I don't think there are any questions, so I think this concludes the presentation.
Okay.
I just want to say also, like, thank you for actually